I think we'll make a start. Good morning, good afternoon, good evening. My name is Karen Zamboni, and I'm a researcher at the London School of Hygiene and Tropical Medicine. And I'm delighted to welcome you to this session on governance, quality improvement, and scale. My job here is to explain the structure of this session and how to participate. But before I do, I will say a few words to frame the issues that we will discuss. Quality is at the heart of universal health coverage. In 2018, coinciding with the launch of the Lancet Global Health Report on high quality health systems, Dr. Tedros stressed that without quality, universal health coverage remains an empty promise. The Lancet Commission report outlined a very compelling case for investing in quality health systems. Poor quality of care is now a bigger barrier to reducing mortality than inadequate access. Specifically in relation to maternal and newborn care, high quality health systems could prevent 1 million newborn deaths and half of all maternal deaths each year. Poor quality negatively affects people's trust in health systems and utilization, and it's particularly important as the burden of disease shifts to more complex conditions. Poor quality of care disproportionately affects poor and marginalized groups, so quality and equity are inherently linked. And finally, as the COVID pandemic has demonstrated in the last year, key processes such as infection prevention and control are at the heart of both quality and emergency preparedness, and unfortunately, they are still far from being standard practice in many settings. The Lancet report in 2018 stressed the importance of taking a health systems perspective to deliver quality of care and proposed a very ambitious agenda to transform health systems. The report highlighted the limitations of strategies to improve quality at the point of care, which the report calls the micro-level interventions, and suggested that these interventions should be accompanied by actions at a higher level of the health system, at national level, subnational level, or both. And this is precisely what we will discuss in our session today. We have a very exciting lineup of speakers and panelists who are all at the forefront of conceptualizing, supporting, and researching strategies to improve quality. In discussion with them, we will explore approaches to link quality improvement efforts at the point of care with broader strategies for quality improvement at the national and subnational level. And we will reflect on what this means for the challenge of taking quality improvement to scale. A final note on terminology. Before, most presenters will refer to quality improvement to mean strategies to improve quality. However, as we all know, quality improvement, or QI, can also mean a very distinct type of intervention, which often consists of what is commonly known as plan, do, study, act cycles. A few of our examples are from QI programs, but when this is the case, we will make this explicit. We will mostly talk about quality improvement in the broader sense of the word. So, coming to the structure of the session, in the first part, we will hear from 4 speakers, researchers and practitioners involved in implementing, evaluating, or coordinating initiatives to improve quality of maternal and newborn care. It's a real pleasure to have with us Dr. Abiyuki Fle from the Institute for Healthcare Improvement in Ethiopia, joining us from Addis Ababa, Dr. Claudia Hansen from the London School of Hygiene and Tropical Medicine and Karolinska Institute, joining us from Stockholm. Dr. Samiksha Singh, who is also co-chairing this session from the Public Health Foundation of India, who joins us from Hyderabad, and Dr. Blurta Maliki from the World Health Organization, joining us from Geneva. All of them will share experiences of implementing programs to improve quality and their reflections and their learning on scaling up. After their presentations, I will hand over to Dr. Samiksha Singh to chair the discussion with our 4 panelists, who she will introduce later and who will build on these presentations. I very much hope that this session will be interactive, and we welcome your participation. So if you have questions or comments, please use the live Q&A function. We will keep a close eye on that, and we will respond in real time if we can. and we will pick up some of these questions later for the panel discussion. If your question is specifically for one of the presenters, please mark it as such so that we can make sure that they respond in the chat after their talk. And finally, before we start with the presentations, I would like to acknowledge and thank Professor Joanna Schellenberg from the London School of Hygiene and Tropical Medicine, who has contributed to the design of this session and is also helping to keep an eye on the chat and will help answer your questions. And also acknowledge our donor, SIF, for sponsoring this session. So without further ado, I would now like to invite Abiyu to take the floor and share his presentation.
Thank you, Karen. I'm Abiyu Kifli from the Institute for Healthcare Improvement. I'm the country director for the Ethiopia project of IHI. I will be discussing with you what we are doing within Ethiopia and how we were implementing quality improvement initiative across the country, which would be discussed in the coming few minutes, and I will be exploring on how we proceed from a prototyping phase into a full scale. So I will be covering a little bit a wide range of activities that we were discussing, implementing in the past 5 years plus. So this project, next slide please. This project is a collaboration between Institute for Healthcare Improvement and the Ethiopian Ministry of Healthcare, Ministry of Health, and it is around a large quality improvement initiative with an aim of improving maternal and newborn health while we build a culture of quality and quality improvements across the country. So the project is mainly based on, we designed it based on the Juran trilogy. As you know, this framework does have quality planning, quality control, and quality improvement as the 3 elements, and quality planning involves strategy development, implementation, and resourcing towards the strategy, and the control aspect covers compliance towards standards so that performance will be within historic limit, and the improvements would require the application of continuous quality improvement so that new levels of performance will be achieved. Next slide, please, Karen. So for the project, we came up with this design framework, and as a center, we have an aim of improving healthcare quality through an institutionalized culture of QI across the system. And for this to happen, we designed 3 elements, namely the national quality strategy, development and implementation support to the ministry, so that the ministry would be running the agenda of quality through a strategy. And the second one, the second element is building QI capability so that people would be capable of implementing the national quality strategy as described. And for the people to be capable of implementing, a demonstration project is required. And this demonstration project was designed around a selected priority area, namely the maternal and newborn health QI project. And to operationalize it, we created 3 phases. A prototype phase based on which we will be exploring how quality improvement mechanisms would be applied within Ethiopia in the real context and across a scalable unit. And by the end of the prototype phase, we develop a change package that could be implemented at a larger scale. And before we go to a full scale, we were required to have an intermediate step, which we named it test of scale phase. The purpose of this phase was mainly to demonstrate an effective mechanism to move towards a full scale and create a blueprint for the national scale-up. And based on the findings from both the prototype and the test of scale phase, we proceed into full scale. And for project management's sake, we had two consecutive projects, the phase 1 project and the phase 2 project, which both were funded by Bill and Melinda Gates Foundation. And as a result of the phase 1 project, we received an award for phase 2 project to cover, to work toward this full scale. Next slide. So we were able to have an internal monitoring mechanism and a formal evaluation process based on which we tried to understand where each of the selected indicators for MNH stands. And here are few selected indicators for the MNH quality improvement work, and at the left upper corner, you see small multiple run charts that were prepared for all of the districts, and we see here a positive trend going upwards. And this indicator represents indicators that are coming from HMIs and how they were affected through the project. And at the bottom is a new set of indicators which we called clinical bundles. And those clinical bundles were new for the country, and we built them based on the WHO Safe Childbirth Checklist. And this also gets quickly implemented and gets sustained of above 80% for relatively longer time period. And on the right hand side, I showed here two indicators as a representative of complication detection, management, and the survival of mothers and newborns. At the top is as a representation for newborn care, and at the bottom is a representation for management of complications among the mother. And we were able to positively affect all of the indicators based on our internal monitoring and formal evaluation process. And the next slide, please. So for bundles, we noticed that 84% of participating facilities were achieving more than 90% adherence to at least one labor and delivery bundle, and 67% of the facilities were able to achieve more than 90% adherence for all of the labor and delivery bundles that were designed to guide the improvement work. And the median clinical bundle adherence was above 80% for all of the three bundles, which is encouraging from project management perspective, and a great lesson for the country also. And we also explored how the coverage indicators were influenced, and at least 70% of the facilities were able to report out improvement in at least one service coverage indicator. Next. So coming to scale-up process, which is a phase 2 work for us, we came up with some suggestion on how to go forward toward this full scale, so that the country would implement quality improvement work across all of the districts in the country. And we aimed to make sure that each of the intervention packages that were applied during the phase 1 work, which mainly encompasses trainings, coaching activities, and making sure that people understood the QI process and apply it in selected indicators. Those intervention packages remain constant as we move into the scale-up process. But the approach toward this scale was a little bit modified in such a way that the responsibilities that were mainly being executed through IHI were transferred toward this government, so that all of the interventions would become more of sustainable when it gets implemented at a large scale. And as you see from the graph on the right side here, we started with the prototype phase in 5 districts only. And then we added 21 more districts as a test of scale site. And we proceed into the next scale-up phase, which is aimed to reach 40% of the districts in a relatively shorter time period, which is defined as 3 years or less. And currently we are just midway into those into the current scale-up cohort. So the key learnings that we captured in the scale-up process was as enabler, linking quality improvement at a macro system level and through quality planning process is critical, and we are addressing it through the quality strategy development, and designing with sustainability and scale as an integral part of the project are also the critical elements. Of course, building capability is key in the implementation, and resource is always needed. The challenges included staff turnover is something to be addressed, and resource limitations should also be included. And the lack of accountability, mainly the consideration of QI activities as a separate activity was a little bit a challenge, and it needs to be addressed. Saying this, I would like to thank you all for having me for this session and for your attention.
Thank you. Then I continue now. My name is Claudia Hansen. I'm Karen, you are moving this, no? Yeah. So my name is Claudia Hansen. I'm an associate professor at London School of Hygiene and Tropical Medicine, as well as Karolinska Institute. And I just put also my video, sorry. I'd like to present on behalf of my colleagues from the school, as well as the Public Health Foundation in India. And I will present learning from a quality improvement collaborative for newborn health in Andhra Pradesh and Telangana in India. So next slide. The intervention was implemented by Access International. That's a quite well-known international NGO, has a lot of experience in public health and also improvement work. And the collaborative quality improvement initiative had classical PDSA, Plan, Do, Study, Act cycle in its center, and it aimed to improve 20 evidence-based practices in the labor ward as well as in the neonatal intensive care units. And it was about quality improvement, including mentoring from Access Health International in the hospitals. It has also some collaborative learning sessions, so some collaborative element. So hospitals were meeting at certain time points, and the initiative did hang with a health insurance company at the state level, and the idea was that they would be saving if neonatal health would actually improve and less money would need to be spent on neonatal health. And the intervention aimed to reduce neonatal mortality. Next slide.
Claudia, please keep going because the slides are frozen, but please keep going.
Okay. So our evaluation aimed to assess feasibility and acceptability and the impact of the intervention on neonatal health, so on neonatal mortality. The evaluation and the included hospitals were public hospitals, but also quite a lot of really high-level hospitals, tertiary hospitals, and colleges in the 2 states of India. So the intervention included in total, or the evaluation included in total 60 hospitals. So these were distributed to 29 intervention and 31 comparison hospitals. We could not randomize them, but they were assigned with a quite good balance. So the whole evaluation used the so-called plausibility design, as it was not randomized. So we did a baseline survey, which included 52 of the 60 hospitals, and an endline survey, which included 39 of the 60 hospitals. And we had a variety of tools, including facility checklists. We abstracted registers, we abstracted case notes, we did interviews, And statistically, we used a difference in difference approach, which I will explain a bit later. So our qualitative analysis used the multiple case study design, and we had interviews with doctors, nurses, administrators, and policymakers. So about the implementation, one of the most important findings is that the implementation actually had quite a bit of attrition. So whereas 29 hospitals were allocated to the intervention, only 7 were still engaged in July at the end of the intervention. So the main challenge was actually that the whole state dropped off this and withdrew the permission for the intervention because the state did not thought that this quality this intervention was really worth to implement it. And the second challenge was that there was an insufficient package. So only about, on average, 5 of the 20 evidence-based practices for hospitals were actually tackled. The next slide. So, and then did it have a positive result? And we have to say, no, there was no evidence of an effect on primary or any secondary outcomes. And here we show 3 figures. That's on stillbirths, on neonatal mortality, and on hand hygiene. And we show here that there was no difference for each of these primary or secondary outcomes. And the difference is here marked with the red arrows. So you take the difference between the light green estimates at the baseline or in the intervention and compare it with the end line results. And the same you do in the comparison area. And then the difference between these 2 differences is the difference in different estimates, which should have shown a positive effect, but it didn't. So, and then the results on feasibility and acceptability. And our key findings, so our evaluation looked at different aspects, the attributes of the intervention, of the implementers, of the adopting organizations, the hospitals, and the socio-political context. And in principle, there was a lot of positive things also with this intervention package, and still it was perceived as incomplete, particularly also as it did not have any training. So the implementing organization, Access Health International, was a well-known public health NGO, but it had a low credibility in this actually high-level tertiary and particularly also the colleges and private hospitals. The big problem was the workload in the hospitals, and quality was not seen as any of anything really that important because the nurses were really struggling with managing the caseload. And it had all a quite complex policy framework, and it was not possible to leverage actually the financial incentive. I explained before, the intervention did hang with a health insurance company, but the newborn piece was such a small piece that it didn't make any difference really for the health insurance. So they became quite uninterested throughout the implementation. The next slide. Yeah, and the learning now along the theory of change. So we believe there were 3 really important points. So the first is that we believe the context was not ready for the intervention. I said the whole state actually dropped off because they didn't consider the quality improvement approach as so important. Then the intervention components did not really meet what the nurses and the doctors in the hospital did need. So they wanted to have much more training, and they also felt that there was not enough coaching and support to really improve and tackle the problems they were facing in their hospitals. So there was a limited absorption of the inputs. So as I said, it was not really accepted. So there was a continuous low motivation and little commitment to really improve quality of care. And the intervention was also never adapted to the needs. So there was no training component added and no additional investments, like, for example, better hand washing opportunities. So, and that is why we believe in the end, we did not see any improved adherence to evidence-based practices. And we also did not see any reduced mortality. As I explained before, no reduction in stillbirth mortality and also no reduction in neonatal mortality. So this confirms somehow that every system is perfectly designed to get the results it gets. And quality improvement would need to much more critically really address all the health system bottlenecks, not only at the facility level, but really also the wider ones. And there need to be an interest in quality first really framed also at the national and the state level. Thank you very much.
Thank you, Claudia, and thank you, Abiyu, as well for your previous presentation. Welcome to those that have joined as we had already started. And just to say, if you have any questions for the presenters, please use the live Q&A function. We will make sure that they get answered either by the speakers themselves after their talk or further down below during the panel session. So now I would like to invite our third speaker to share experiences from programs in India. So Samiksha, if you want to take the floor, please.
Hi. Thank you, Catherine. Good morning, good evening, everyone, wherever we are. I'm here from Hyderabad. So this particular project which we are talking about is not a typical QI-based project. However, it was intended towards improving the quality of care in labor rooms based on a WHO Safe Birth Childbirth checklist. This particular program, which we are going to talk about, was first pilot tested in one of the states of India based on the success which we saw in reducing the perinatal mortality. It was adopted as a nationwide program. And what we evaluated was the scale up of that pilot as a nationwide program in 2 states. Next slide, Karen, please. So I'll just give you a brief about the program before we go into the evaluation. So the main strategy here was, unlike the learning from what Claudia was already said, the resources and the readiness of it. So they invested heavily into gap identification and resource availability throughout the program. Next, Karen. So they invested a lot into readiness, looking at what the items would be required, and also inbuilt a periodic assessment and supported the facilities for local problem solving. So this continued throughout the program. Next, they ensured that they do focused and customized training as per the need of the state where they are implementing this program and the readiness of the facilities. So the training was not just about the items in the WHO Safe Childbirth checklist. In fact, they were coupled with the skills to be gained to be able to implement all those aspects in the checklist. So it was a 3-day training with skill-based approach. They also ensured that the training was closer to their workplace. So rather than having a central area where the trainings would happen, they were more in their own districts. So the culture in which they had the trainings was more where they belonged to. That made it more acceptable and more comfortable. Another special feature was to use standard pedagogy for imparting these trainings. So even if you have trainers doing it, but the way it was done and taken to the peripheral level was more or less standardized. That was one of the key features of success of the program. Apart from these trainings, next they looked into the strategy, how these trainings can be transferred into actual skills, upgradation, and to practice. And that was supported by mentoring and supervision. They developed a 8-visit package, which was later on revised to a 5-visit package, where they did mock drills and demonstrated along with the workers how those activities have to be done in their workplace. This helped the workers to really practice those under the supervision, note their minor challenges or errors, and get a feedback in their workplace and improve the practices. This also helped in team building. The way the mock drills were planned was that the team together used to do it and their supervisor. So if the nurses are involved in an activity, the audit was conducted by the obstetrician or the medical officer. So the team comes together, they together learn what the mistakes are, and they together identify the problems and the solutions. So it was not a typical PDSA kind of approach, but the mentoring coupled with audit and discussion of the problems and gaps then and there was some kind of a package looking at the problem identification and solutions, and looking at sharing these practices in even district review meetings where the facilities would share their learnings. Next, they focused a lot on improving the monitoring and accountability part. Before I move on to that, so because we looked into, yes, Karen, please, next. We evaluated in 2 states. So Rajasthan state is a poor performing state. There, the program had external mentors doing the mentoring and supervision. They were hired by the implementation partner, which was Japaigo India in this case. And in Andhra Pradesh, it was considered as a better performing state where the resources were better and the engagement with the state was in a different format with the partner. There, they identified in-facility government mentors. So the mentorship was a totally different implementation strategy in both the states. And that's why when we saw the results and when we present our results and take it to the state or other stakeholders, we treated these two as 2 different interventions and 2 different evaluations. So when we come to the results, I'll point this thing again. So the 4th strategy which they emphasized on was improving the monitoring and accountability in the system, which was by increasing the use of data. Next, please, Karen. And periodic assessments were done quarterly. They use an IT application. The best part of that IT application was it could give the score of performance at the site itself. You could give feedback immediately, and it would go into the server and into the system. Even it could be monitored in real time from the district and the state level. So this would help the district administrators and the state administrators also to monitor the performance of the mentors and the visits of the mentors and what issues have been tackled in real time. So all of this together was aimed to improve the best practices. Dakshata program focused on 29 best practices, improve overall accountability, and in overall reduce the perinatal mortality. So that was the overall structure of the program as well as the support provided by the implementation partner. Next, so we were to evaluate this program. So we used mixed methods. We did not have opportunity to have baseline because by the time we started the evaluation, the program has already started in both the states and in all the districts. So we could not have baseline, neither could we have controls. So we looked at repeated cross-sectional surveys, and the timeline also what we had was limited to have multiple data collection points. So we had 3 data collection points for Rajasthan and 2 data collection points for Andhra Pradesh, and we used mixed methods for this evaluation. In Rajasthan, we went to 30 facilities, and in Andhra Pradesh, we went to 23 facilities, and this was all after calculating sample sizes properly. So in mixed methods, we had the quantitative approach and the qualitative approach. So as you may be aware, that WHO Safe Childbirth Checklist has 4 pause points. And the pause points are around admission, during delivery, immediately after childbirth, and during discharge. So we identified 5 best practices, measurable best practices for each of the pause points and computed their averages. The results will show that. And in the qualitative aspects, we looked at the effectiveness, the accountability, monitoring, sustainability, and scalability of the program components. Next, please. So coming to the results, as I told you that the districts were in different stages of implementation. So we selected districts in a manner that the intervention was at different stages, from bulk training to mentoring to need-based mentoring. So that was group 1. So what was happening in group 1 was that at the time of when the trainings were going on, we consider it almost like a baseline, all the trainings were going on. We see by the time the mentoring is ongoing at the interval of 6 months, you see slight improvement in both at the practice at the time of admission, at the time of birth, not much change in the practices within 1 hour, and some changes in the time before practices before discharge. As the time continues, although the intervention was planned just for the mentoring package, but the implementers and the partner agencies, they realized that it was not enough to improve the practices up to the acceptable level and sustain. So midway between the program, the adaptation was done to need-based mentoring. So what that meant was that when periodic assessments were done, wherever the gaps were identified, there the strengthening of the practices would be done by repeated mock drills and continuation of emphasis on the ongoing practices. When the need-based mentoring also continued, you see that the practices further continue to improve. And simultaneously, you see that after the mentoring is completed and the need-based mentoring continues, you also see sudden reduction in the stillbirth rates in this group of facilities. Next, please. Then there was a second group of facilities where when we started the evaluation, the mentoring had already completed. The intention here was to see how it is sustained and how it improves if the need-based mentoring continues. So over a 1.5 period of time, years of time, we saw that when mentoring completed, clearly you will see that the indices are higher than what was in the baseline for the previous group. But when the mentoring was stopped, there was a drop in the practices. And this was due to several reasons. There were new recruitments, there were some changes in the facility infrastructure happening. And at the same time, here, the implementing partner was figuring out a shift from mentoring to need-based mentoring and how that should be done. Because of a lot of systemic changes that were happening, they saw a drop in the practices. And that was an instant pickup because due to periodic assessments, and the system immediately realized we were not ready to let go mentoring. We would need to continue the mentoring. And that's when the need-based mentoring continued. And you will see that because of need-based mentoring and repeat trainings, the practices again improved and they continued to improve. That was important learning here. Next, please. So if we compile all these stages of intervention together and all those indices together as an average of each pause point at admission, at birth, within 1 hour. So these are the averages to represent. From bulk trainings, as the mentoring goes on, there is improvement. When mentorings are completed and there were some infrastructural or human resource changes, you see a drop in practices. But when you come back and you continue your need-based mentoring, there again increase in the practices. Overall, there's improvement and it reached up to 80% average. However, there was more intervention required or more focus is required for pause point 4, that is the practices during before discharge. And there are multiple factors which contribute to poor start to begin with. There's improvement, but a lot more is possible. Next, please. So in Andhra Pradesh, as it was a different model, there was just in-facility mentors. We saw that it started high in terms of performance, except for pause point 4. Most of it sustained. Only the practices during birth, they showed improvement from 78% average to 86% average, which was significant. Rest, they were sustained. This model qualitatively showed a lot of promise into the feasibility of using in-facility mentors and showing improvement in one of the aspects, one of the pause points. However, it will require more in-depth understanding how this in-facility mentoring works to use it for other pause points as well. In overall, quantitatively, we do see a reduction in stillbirth rate, and we do hypothesize that it is linked with the improvement in practices in admission and improvement in practices at birth. But this is just an hypothesis, which will require further more modeling and testing to prove this relationship. Next, please. So we had a strong qualitative aspect into it also. So I'll just quickly give you the factors which were contributing to the effective implementation. The first being that it was a national program and it had a lot of force from the national government, a push from the national government, which made states also to pick it up. And both the states where they had, these were the first few states to take up the program. So they were more volunteering in a sense or leading the program implementation at the state level. So there was strong ownership and monitoring from the state. There was sustained external partner support throughout our evaluation and even during the phase out. The key feature was they invested heavily into preparedness and ensuring that basic resources were in place before the trainings and the mentoring started. And the standard package, what they have built with the possibility of adaptation at the local level, repeated cycles, and further modifying into a need-based mentoring was an approach which showed improvement. As per the stakeholders, mentoring and periodic assessments were the strongest pillars of success of this program. External coming and doing periodic assessments and telling them where they stand was the key feature and motivated them to work. The way the mock drills and the relationships were built between the teams, mentors, and facility leadership was also highlighted as a successful point. Nurses were highly empowered and they gained voice. In settings like India, there are a lot of hierarchies, and in that kind of a setting, a nurse having a voice to be able to do things was a big achievement. Next, please. So there's still a lot of challenges. We realized that POS point 4 was not priority for the staff because there were no dedicated staff for the postpartum ward. It was the staff in the labor room who had to complete their task in labor room and then do the activities in the postpartum. And also they felt once the child is delivered and whatever the outcomes are, they are more to be taken care of after discharge. So it was not a priority, and we call them sticky practices. There were quite a few of them which did not show much improvement even after repeated mentoring. So we need to look more into how to strategize the implementation of behavior change around that. This periodic assessments were still done by the externals. Even in-facility mentors were not well versed or motivated to do periodic assessments by themselves. So it stays a challenge. For quality improvement, I'm sure all others would have faced a problem with audit and using of their own data. Similar kind of problem we noticed in this intervention also. I've mentioned hierarchies in India in health systems. They are a big limitation in this kind of a setting. Monitoring and accountability stays still as a challenge. More than that, what is a challenge is the outlook of the state and district leadership about quality itself, and the culture of how to look at quality, how the quality can be improved beyond just infrastructure is a big challenge. Mentoring, although showed improvement, is not yet considered as a long-term support to quality improvement or skills upgradation in the system till date. Next, please. So for scale up, I'll just conclude that even in these two states, the phase out was planned, well planned, and they planned in a manner that some support should continue. But so external support has to continue, maybe more at a state, at a district level for administrative and managerial support. But the periodic assessments will still need external support and feeding back into the system. We have other programs which have come in the meanwhile, like Lakshya program. I'll not go into the details of it, but it brings in both skill upgradation, accreditation, and quality improvement, the PDSA approach, into one umbrella, and how these programs embed the skill upgradation and mentoring embed along with the infrastructure and PDSA would be interesting to see in the times to come. Last point here for the scale up of any of such program is that it will depend a lot on how the health system of the particular state or the district is ready to adopt such kind of a program, how committed they are, and how committed they are in terms of not just giving go ahead for the program, but in terms of administratively managing it and monitoring the program, because the force largely comes from the monitoring from the state leadership, even if you have an external partner. So thank you. Here I'll close my presentation. Thank you very much.
Thank you, Samiksha, for your presentation. And I would now like to hand over to Dr. Blurta Maliki from the World Health Organization. So Blurta, over to you.
Thank you very much, Karen, and thank you to all the previous presenters, because now I will move into a different level, while the other presenters, they showed the results from their projects at the service delivery level. I'd like to bring now the experience of 10 countries that have tried to build systems and structures around quality of care and quality improvement. My story starts where your story started, Karen. The story of maternal, newborn, and child health is one of great progress and remaining challenges. Despite significant increases in access and coverage of health services for mothers and children, a staggering number of women and newborns are still facing morbidities and mortality, disrespect of care, and poor quality of care. The Lancet report on high quality of systems told us that good quality of care can prevent almost half of maternal deaths and over 60% of newborn deaths in low and middle income countries. And it is in this context that countries have committed to improve quality of care for MNCH, to deliver on SDGs and on the global strategy for women's and children's results. Now, my story starts in 2016 when WHO issued the standards of care for the quality of care for maternal and newborn health in facilities. Following the standards in a series of consultations hosted by WHO and involving government representatives, UN agencies, funding partners, and more importantly, implementation partners, discussed what was required to build systems that support the delivery of quality of care in an effective, scalable, and sustainable way, and assist countries in achieving the SDG targets. Well, the consultations noted that most quality improvement efforts were project-based, that they did not survive initial funding, and promised little for scaling up and sustainability. At the same time, the consultations, they discussed, agreed, and recommended that more learning was needed to understand how to implement and sustain quality of care that should be put, and that effort should be put towards building a facilitated global learning network on quality of care. It was perceived that such a network would offer a tool for sharing learning among countries and partners, generate solutions or ideas on how to address the most pertinent challenges on quality of care for MNCH, and then bring attention to the broader health system issues that underpin quality of care. And let's not forget that this is now end of 2016 and early 2017. By February 2017, 10 countries of committed governments to quality of care and improving quality of care for MNCH, and those are Bangladesh, Cote d'Ivoire, Ethiopia, Ghana, India, Malawi, Nigeria, Sierra Leone, Uganda, and Tanzania, together with WHO and supported by a coalition of partners, many of them are in this call today, in this meeting today, established the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. The network was purposefully established as a platform to facilitate the formation of alliances around MNCH and quality of care and to enable sharing of learning among countries. Next slide, please. The 10 countries recognized that improving quality of care for women and newborn during childbirth was a priority for addressing preventable MNCH mortality and therefore a critical point for improving maternal and newborn health outcomes. Driven by the values of quality and dignity, equity and dignity, and sometimes we hear about the network being called the QED network, all countries committed to halving maternal and newborn deaths and stillbirths and improve the experience of care for women and children.
Karen, sorry, network is Blair, sorry. Your sound is not coming through well. Could you just mute and unmute yourself just to see if that solves the issue?
What about now?
No, it's not better.
I need to log in again. Zoom sometimes creates this problem. I don't know why.
Okay.
I'll come back in a minute.
So while we wait for Blurta to come back and continue her presentation, just wanted again to draw your attention to the live Q&A function. If you have any questions for the presenters, please put it there. I can see there's a question there from Antoinette. I hope we'll have time to take it up after the talks. If not, then I'll ask Claudia to deal with it in the chat. And also to mention that after the talks, we're going to have a very short live poll to gather your views on effective implementation features of strategies and programs to improve quality of care, and also your views on what contributes to effective scale up of these programs. So stay tuned and be ready to participate in the poll. And maybe since I don't see Berta back yet, can I ask Claudia to come back in and maybe offer an answer to this question by connect? Oh,
can you hear me?
Yeah, Berta, we can hear you now.
Okay, great. So you are, yes, strategic objectives and the vision. I think the vision I got through.
Great.
Okay, so on the strategic objective, so building on that vision of having maternal and newborn deaths in facilities within 5 years, there are 4 strategic objectives that the countries agreed to pursue. And those are leadership, which means building and strengthening national institution mechanisms to improve quality of care, action on accelerating and sustaining implementation of quality of care improvement, and especially through a quality improvement lenses, learning, that is even the network per se, it is a learning network, so it is to facilitate learning and sharing knowledge and generate evidence on quality of care. And finally, on accountability, that goes beyond data. It is about developing and strengthening institutional mechanisms for accountability on quality. Next slide, please. One of the characteristics of the network that is that over the last few years, jointly with countries, we have co-developed what we call the network implementation approach, the monitoring framework, and all the learning network that comes along to support the implementation. So allow me only a few minutes to describe what are the key elements around the network country implementation approach. This approach builds on the principles of government leadership and multi-stakeholder partnership. It recognizes the need for a health systems approach to enhance quality of care, and it requires a common understanding by all stakeholders who are engaged in delivering quality of care across all levels of the system. More specifically, it emphasizes, next slide please, it emphasizes the need for an overall strategic direction for quality on health services, and we have chosen MNCH as an entry point, or as a pathfinder for understanding how the system should behave to support delivery of quality of care. At the national level, the network is the implementation is led by the Ministry of Health, that brings together a large coalition of partners, which is under the label of a technical working group on quality of care for maternal and child health. This technical working group, together with ministry, they develop what is called the roadmap and operational plan. That is an integrated part of the quality of care strategy policy and MNCH plans that allows everybody to align their resources as well as their activities. Now, within the roadmap, the countries have identified what they call learning districts. Important to highlight what is the role of the learning districts. While activities are happening across the countries, the role of the learning district is that of a laboratory of implementation. The learning districts are representatives of others in the country, so is the average district in the country. So the learning that are generated from these places can be generalizable across the countries. And then the selection of these districts is based on the commitment of their teams to learning and to quality of care. Now, there is a very strong element that comes with the learning district support, or the support to districts and facilities. And those are 5 fundamental requirements, we don't want to call them systems, that enable the implementation of quality of care. The first of all is on-site support, which aims to institutionalize the implementation of quality improvement methods, and then to provide that on-site support that implementers or service providers at front lines require. The second is around learning, which aims to establish learning systems within and across facilities and providers within the districts and across districts. It encourages peer-to-peer learning as a means for systematizing and accelerating sharing of experiences, but at the same time, we see this as a channel for feeding back into the changing management decisions, as well as policies around service delivery and quality of care. A third element is quality of care measurement that is critical for demonstrating whether quality of care is improving and results are achieved. And the measurement includes a set of common indicators, 15 maternal newborn health common indicators that countries have identified within their existing systems, with exception of those that are around respectful care that most countries do not have in their existing systems and for which they are working to collect. And the final 2 are around community engagement and program management. On community engagement, the voice of people is very important in defining quality, but also in delivering quality of care. And program management is required for both changing the culture within service delivery. We already heard how important this is to change it, to appreciate quality of care and to build the structures around that, as well as to manage the delivery of quality improvement. Next slide, please. The network has gone through a live course, and now it's almost 4 years, and that has gone through different milestones. Within those milestones, I think the most important are those in relation to co-development, sharing, and learning. And that co-development, sharing, and learning has happened around very specific events in which countries have joined each other and have shared what they've done, as well as have informed what they need in terms of support. So that has been the result of those type of interactions, have been the co-development of the implementation guidance, co-development of the monitoring guidance, of the common indicators of the learning, and so on. At the same time, those were the events in which countries could share and be accountable to each other in terms of where they are in the implementation of the network objectives. Next slide, please. So at a glance, I would like to share with you where these countries are. So 3 years in the implementation, where are they today? In line with the strategic objectives, implementation at country level began with the focus at the leadership. Activities were directed then towards action, and now they are addressing more the elements of learning and accountability. In the slides in front of you, you can start from the bottom, which is mainly around the leadership, and then move towards the upper part that is mainly around learning and accountability. And as you see, the green becomes more orange and red as well, and that is just because the activities on these areas, especially at the very beginning, were not developed. Now, at a glance, we do have some of the findings around the leadership, action, and learning that I would like to share with you. So over the last 4 years, all the countries have been very successful in keeping the quality of care agenda on the top of their national health agendas. However, and that we think is because the ability of the network to stay flexible and to respond to country needs that has been fundamental. The national quality policies and strategy and related roadmaps have been successfully developed and implemented. However, despite this initial investment, more funding will be needed to scale up the implementation of quality of care and quality improvement capacity building. And that is because the governments have started to invest domestic funding into the area of quality of care. National technical working groups that coordinate government and partners are effective and they continue to exist. However, we have seen that this coordination has not always led to partners changing either their technical support objectives or the funding cycles. And then finally, leadership structures for quality of care have been built, which is quite good, but at times we have observed tensions between the new quality of care structures and existing, let's say, MNCH programs that are in charge of implementing quality for their programmatic aspects. And that is mainly due to absence of roles and responsibilities, clarity on roles and responsibilities. On the side of action, one more minute on the previous slide, progress has been made around the development and adaptation of the standards. However, we have seen that from the learning district, scaling up of the experiences within the network countries does require continuous technical assistance, and that the current structures and systems at national and subnational level do not have the capabilities that they require to sustain this type of implementation. And to build these capacities, partner support is more needed. And then finally, on the learning and accountability, it was successful to have a common set of indicators agreed among countries. However, progress in documenting and sharing this data varies a lot across countries. And they reflect the capacity of countries to deliver on this information, as well as the overall systemic constraints of their information system. Progress is being made around quality improvement and learning systems. However, the institutionalization of learning systems at the district and national levels will depend completely on strengthening the coordination between the knowledge generation and sharing processes and stakeholders, and policymaker and program management processes and stakeholders. Next slide, please. So today we are still in the middle of the implementation among the 10 countries. However, we have a number of lessons that we have observed, and I think it's important to share them now and have them as a point for discussion. First of all, it takes a whole health system to improve quality of care. The implementation of quality of care agenda has advanced in countries that developed those policies and strategies and started to set up dedicated quality improvement structures, quality improvement capacity building for health managers and implementers across all levels. Government leadership and long-term commitment is a prerequisite. Quality of care may not always be a priority in resource-constrained environments, so where we have different competing health needs. However, it is critical to identify and engage key decision makers and policies and influencers so they can make the case to invest in quality of care and to create what is most important, the enabling supportive environment. Substantial time and long-term commitment are needed to establish these structures. Attention must be paid to addressing, managing, and potential tensions between quality of care structures and the existing programs. Quality of care requires dedicated and sustained investment. This agenda does not exist in isolation. Investments in all systems are needed to strengthen quality of care. We believe that financing initiatives such as Global Fund or GFF, they should support the national country-led quality of care agenda. We have seen that the network countries have seen success when government was on the drive. However, we know that at the short and medium term, governments alone cannot mobilize the level of resources required to sustain a large system-wide change. And partners' engagement for this is going to be very important and remains critical, especially in relation to quality improvement capability development. Health systems operate in different contexts, which impacts the pace of implementation and adoption. It is important that while the quality of care approaches and strategies are aspirational, it is very important at the same time to be realistic and to have realistic expectations about what and by when these strategies and interventions will achieve their intended results. We know that the quality of care is not a panacea for the unresolved problems on health services, especially investment on fundamentals of the health system's delivery. And there we should recognize that teams that get engaged on quality improvement they get very enthusiastic about, but there is a real risk of exhausting enthusiasm for quality of care if systemic resources and systemic gaps and resource gaps that are identified during the quality improvement are not addressed. We have lessons learned around building QI capabilities that are necessary for sustaining the improvement, investing early and intentionally in the development and strengthening of data system that is completely essential, and that developing implementation and monitoring of a comprehensive and adaptable quality of care program at a district regional level is critical. These 2 points are interrelated. Data systems for quality of care reflect the strength of data systems in the country, while the implementation at the district or subnational and facility level does require very strong elements of design, including data. Demonstrating impact takes time. It's more difficult if one has to compile different types of activities that are happening across different facilities with different approaches and try to see what is let's say, the impact of all of them. And then finally, documenting and sharing lessons learned is important. We find that documenting the context so one can understand why things have happened in one way or another is very important in addition to the data. The next slide has some of the resources, and I'd like to thank you all, and I'm sorry for the glitch. Thanks.
Great. Thank you, Blerta, and thanks to all the speakers, Claudia, Abiyu, and Samiksha for your presentations. We're now moving to the second part of this session, which is the panel discussion. But before we do, a reminder again to pop your questions, if you have any, in the live Q&A function. And I will also now start a live poll that I mentioned earlier. It consists of 2 questions. So this is your chance to share your views about what you think are the key ingredients for effective implementation of quality improvement strategies, and also what can help to take them to scale. And whilst you take your time to maybe have a stretch and participate in the live poll, I will hand over to Samiksha to start chairing the second part of this discussion. Thanks.
Thank you, Karen, and thank you all the speakers. I hope the poll is on, and for all the attendees, while you read these questions, please note there is no right or wrong. It is about your opinion and what you have felt after listening to all these presentations. So your answers would be useful, and we'll summarize them as we go ahead. While we move into the panel discussion, and Blerta, the last speaker, had very nicely summarized the important points which are required for a large-scale quality intervention program. And as she said, and she started with that conclusion, was that the quality of care has to incorporate all aspects of the health system from top to bottom. It starts from policy, but goes up to the level of micro level planning and implementation at the facility level. So it has to incorporate all aspects of the system rather than just one facility or one local program. So with that, we would like to start our panel discussion. While you all continue to answer the questions, I'll take this time to introduce our panelists. So we have 4 panelists in this session. I'll give you brief bios for each one of them, and I welcome all 4 of them for this forum. So first we have Dr. Matthew Nielsen, who works with WHO. He is a public health doctor from UK, and he works with the quality team at the World Health Organization in Geneva. Matthew has worked with WHO to support a range of health system strengthening initiatives, including leading projects on quality of healthcare, health services preparedness, and essential public health functions. He currently works on the WHO National Quality Policy and Strategy Initiative, advising countries on setting national strategic direction on quality of care and supporting provision of quality essential health services in settings of fragility, conflict, and vulnerability. Next, we'll have Dr. Catherine Semraw. She works with Ariadne Labs and was leading the Better Birth program, she was a director for the program. And she also works as assistant professor at Harvard Medical School. She has over 19 years of experience in maternal and child health and epidemiology. She oversees implementation and research for ending preventable deaths of women and newborns through evidence-based, scalable solutions and improvement of quality of care. Her current portfolio builds on the Better Birth trial of the WHO Safe Childbirth Checklist, focusing on quality of care for low birth weight newborns. Dr. Semraw has a PhD in epidemiology from Boston University and an MPH from the University of Alabama, Birmingham. Welcome to the panelists. Next, we will have Professor Mike English, who currently works with Bill and Melinda Gates Foundation. He is a professor of international child health at University of Oxford. He works as part of the KEMRI Welcome program in Kenya in collaboration with the Ministry of Health and is a co-lead for its health services unit. He established the Clinical Information Network in 2013 that is now run by a consortium of Kenyan investigators and employs learning health system principles across 20 public hospitals in Kenya. In Oxford, he co-leads the Health Systems Collaborative. He was formerly a commissioner for the Lancet Global Health Commission on High Quality Health Systems. Lastly, I welcome Dr. Hema Magge. She is a senior program officer for newborn health at the Bill and Melinda Gates Foundation. Sorry, I mixed the two. Mike works is a professor in international child health at University of Oxford. And sorry, Hema works with Bill and Melinda Gates Foundation. She's a pediatrician and holds academic appointments at Birmingham and Women's Hospital Division of Global Health Equity, Boston Children's Hospital, and Harvard Medical School. She was previously the executive director at Institute for Healthcare Improvement in Ethiopia, where from 2016 to 2020, she oversaw all technical and operational aspects of a large-scale improvement program supporting the Federal Ministry of Health implementation of the National Healthcare Quality Strategy to drive improvement in the quality of maternal and newborn care and outcomes. I welcome all the 4 panelists, and before I invite them for their insights into the presentation, Karen, if we have the participants answered the poll, can we have the results on?
Yeah, you should be able to see them now.
Well, I can't see the results.
Okay, so maybe I can mention them. So the key feature of the influencing effective implementation of quality improvement, 80% of respondents mentioned that in their view, the context was ready for quality improvement, and 20% talked about selected there was a clear direction for quality assurance. And then in relation to supporting scale up, what would be the most crucial factor to consider? There's a bit of a split. The majority mentions bringing on board stakeholders with decision-making power, that 75% of respondents and 25% mention aligning support to quality improvement to supportive supervision.
Right, great answers, and I'm sure in various settings, each one of them may seem a priority. But now we would invite our panelists to first give their insights into the presentations and the program interventions that were mentioned earlier. I will invite them in the order. First, I'll invite Matthew, followed by Catherine, and then I'll call upon other names. So Matthew, over to you. What your insights into the presentation so far?
Yeah, thank you very much for the presentations today, very informative and thought-provoking. Just reflecting briefly on each talk, Dr. Kifli presented some important lessons from Ethiopia on the need to think beyond quality improvement and consider the assurance needs, the planning needs, and clearly described the need to design from the start for scale and sustainability, and to link quality improvement with planning at the macro level, including, as he highlighted, the national quality strategy. The Ethiopian experience, I think, gives us some important food for thought on how to move from projects to something more like institutionalization and a culture of quality. Dr. Hansen then emphasised the role of the state level inter-hospital collaboration within the Safe Care Saving Lives programme, but noted that some of the difficulties and the need in moving towards a culture of quality. I think the presentation demonstrated that improved adherence to evidence-based practice is very complex and requires actions at multiple levels to make that fertile environment for change to happen and be sustained, which of course has come out clearly in the poll as well just now. Similarly, Dr. Singh then mentioned the importance of national direction, subnational ownership and facility action, the local informing the national, while ensuring that facilities are given the practical support to identify and remedy the challenges in the QI process. I was interested in the point in the lessons learned around engagement of doctors, and then subsequently as well the lack of authority for nurses to make change. I think this shows the need for health system support to think beyond QI specifically and consider some of those institutional dynamics that can shape change. Dr. Maliki described some of the lessons from the QED network, which has been a real champion for the system-wide approach that focuses simultaneously on the actions required across multiple levels. The learning from the network countries highlights the need to both start fast with improvement activities at the point of care and then set that national and subnational direction on quality. I think the network experience also highlights that there's lots that we don't know, emphasising the need to build national and global learning systems that can generate learning on those complexities of improving quality of care and ensure that that learning is shared effectively. So I think striking really, as others have already picked up on, was that there's clear agreement across these presentations for quality improvement at the point of care to be optimised using an approach that supports quality planning, quality improvement, quality assurance and action across multiple levels. So thanks. Back to you, Dr. Singh.
Thank you, Matthew. That was very well put and very important points from each presentation highlighted. I'm sure Catherine will have some more to add. Catherine.
Great, thank you so much, and thanks everybody for joining us today. I think, like Matthew noted, there are a couple of striking themes across the 4 different presentations that I really wanted to highlight that jumped out to me. One is that idea about leadership at all levels and requirement of their buy-in to actually create change and address the quality of care needs that we have, but it does require different strategies, outreach, advocacy, and efforts with different levels of leadership that I think we need to understand and unpack more granularly. And I'd love to hear from our panelists, from the presenters about, what that looks like in terms of being able to create change at different levels with leadership. The second thing that came through that Blerta actually highlighted quite a bit in her last slide is this idea of time, that it takes time to create change. And I think oftentimes we think change is going to be rapid or spread easily or spread quickly. And I think there's this idea about really staging out energy to be able to have bursts of energy around improving quality of care and not just expecting it to happen immediately, but thinking about the long-term planning that is required in order to create health systems change, which may be slow and incremental, but over the long run can create the change. The third thing that popped out to me quite a bit was this idea of readiness, and it even came up in the poll that we just highlighted about this readiness or context for quality improvement. And in my comments a little bit later, I'll get into further about why I think it's not just about readiness, you're either ready or not. It's actually a continuum of being able to take on new interventions that we need to really think about. And I heard that come through with Abiyu's point about having a incremental process that was being able to understand what places could take on quality improvement in the setting in Ethiopia, and then being able to create the final change. And then that relates into my fourth point, which is really about this idea of the scalable unit. Oftentimes, as noted in the HQSS Lancet Commission, it's not always the micro changes that are happening at an individual facility level, and it's not necessarily all the things that are happening at a national level, but it's really about what is that scalable unit, whether that's a district, a county, a health system network, that we need to think about how quality improvement can change with that scalable unit. And again, not making it too small, but also not making it too large, that it becomes ineffective. So just a lot of gratitude to the 4 presenters and hearing about the experience of change. And it certainly resonated a lot with our experience in the Better Birth trial in Andhra Pradesh, India. So I'll hand back to you, Dr. Singh. Thanks so much.
Thank you, Catherine. You posed few points. I guess we are going to pose the same questions back to you. So yeah, next, Mike, may I request you to share your thoughts about the programs and the presentations?
Yeah, thanks very much, everybody, and pleasure to be with people. I'll try and keep this really brief, fairly brief, because I think my colleagues have already made some important points. I guess the first question for you to think about as an audience is, why would academics be involved in any of this stuff? You know, making health systems better, surely that's what everybody should be doing who works in the thing. Why do you need an academic involved? So I'd really like to pose a couple of questions to you as an audience, and maybe to the presenters. Is why did you choose to use those approaches to intervene? Was it because you knew there were problems? Were the interventions targeted at some things you knew were not happening well, or were they just because this is the intervention package that we all use? And I think it's an important consideration, and it comes back to this issue of context. If you don't really have a good handle on your context, then are you choosing the right way to intervene? And I think that goes from the micro level up to the macro level. And then just again to remind people that what appear to be simple transferable words contain huge amounts of meaning, but not necessarily the same meaning to everybody. So we heard quite often issues like mentorship raised. Well, what people mean by mentorship and how it's enacted can be very, very different things. And I think being able to get clarity over that as best we can is also important. I think obviously common across all of our work, and I would include myself in that, is this issue of data as well, and good data. And again, it's a question posed at this point in the 21st century, why are we not able to measure things often as basic as whether there are stillbirths or whether there are neonatal deaths? Where have systems gone wrong already that they can't do these things? So this is, again, a point for all of us. Should it be up to an improvement intervention to fix such fundamental flaws in the system? Or should the improvements be happening on top of a system that has at least some basic functionality? And this, I guess, comes back to readiness. I'm not suggesting that it's black and white like that, but we should be asking ourselves these questions. Again, maybe from a more researcher style perspective, again, we heard several times mention of things like mixed methods, and learning carefully is important, and we use the words quite not always carefully. and mixed methods are a very large and diverse set of methods and need to be, there are good ways to do mixed methods research and not so good ways. So getting the answers may depend on how carefully you've used your approaches to get the answer. So that's an argument for people like me to get involved. So maybe self-serving. And I better finish there, but what I'll try and come back to later is the word software, which is bandied around now in health systems speak for the people that do things rather than the items that are used. And I thought we heard a lot about that. And for me, that is critical. So I hope we'll have more of a discussion on that. And I guess the big long-term issue for everybody is how do we transition from partners to systems? We can't continuously rely on external partners to do things. I appreciate they are needed, but this must be at the back of our mind. How do we move to fully embedded systematic approaches that are locally owned? But let me stop there. Thank you.
Thank you, Mike. We are glad to have an academician on the board and who is talking about such important pertaining questions and looking way ahead towards systems being able to manage it themselves rather than just the partner dependence on the partners. We look forward to that kind of discussion for sustainability and scalability both when we come with specific questions to you all. Lastly, I invite Hema to give her view upon the presentations.
Sure, thank you all. First, thank you to the speakers for sharing in such a short time very rich and complex programs and some of your learnings, because I think that those highlight a lot of key themes, and my colleagues have already covered quite a bit of the key themes. So I'm trying to maybe build upon that. I think in this vein of taking an academic approach, I think one thing I observed in all of the presentations was that I think the most successful programs were really emphasizing this comprehensiveness of design, thoughtfulness of design to using a framework of approach that was looking at the whole system and the components of a system that needed to function in order to achieve the results that were desired. And in many ways, that kind of relates to the theme Mike just said about of an academic approach. And I don't mean this necessarily in the kind of formal institutions, but more as a way of thinking. And saying that, some of the program that we need the same amount of rigor and discipline that is applied in evaluations to the actual program design and implementation itself. And I think that's what you see in the examples, particularly highlighted in the Dakshata program and the Ethiopia program, where they were really thinking about what is the whole system need, what are the key what are the needs and desires of the country, and how do we think through systematically an approach to achieving that. And so, using frameworks can just be an enabling way to help with that thought process, but, ultimately it's not specifically whether you use the Duran trilogy or something else, but it's really about thinking through the problems very clearly, and approaching it in a way where you really try to identify both the hardware, as Mike alluded to as well, the kind of technical skills, the health system building blocks, what exactly the money, the HR, the staff, as well as the software. What is it that the people who act in these quality structures need to actually do their jobs well? And how do you actually create a culture in which people have the natural incentives to do what they actually showed up to do? And often that is lost in the resource constrained and stretched systems that people are asked to work in. And so I think that was this rigor of design and this rigor of implementation were two themes that really came through. And that it's that rigor of design and implementation that allowed for and that led to approaches that actively support the findings of the HQSS. That you need to have some micro level work as an engine of improvement, but that isn't going to go anywhere unless that's really tied into more meso and macro level changes. If that learning in a rural health center is not connected to better planning and governance from a district and resource allocation, or the HR staffing that's required to address that key staff turnover, it's not going to go anywhere. It will just stay at that partner support. And so I think that that was one of the hallmarks of some of the more successful examples that were shared, was really engaging in that process in a both intentional as well as adaptable way. And so they had the learning systems in place to be able to monitor the implementation with rigor and to adapt and change as needed to try to achieve the results they were looking to achieve. And so I think those were some of the key takeaways that I had from the speakers, and really appreciate their hard work and commitment to working with governments to help them achieve the goals that they have.
Thank you, Hema, and thank you all the panelists for their insights. And it has summarized and brought about to the fore the important points of consideration. You've also raised a lot of questions back to us, and as well as for the participants and everybody working in quality of care. But because of the time constraint, and we would really want to focus on key aspects, and scalability being the theme for this panel discussion, I would now like to ask specific questions to you all. So first, I'll pose a question to Matthew and Catherine. Matthew can answer first, followed by Catherine. So the question for you both is linked to where Hema closed her talk, which was basically that the systems should be coherent from what we learn at the end facility and linking it with the governance. So the specific question is, how to improve coherence between quality initiatives at the point of care and governance for health systems quality? Matthew, would you like to take it first?
Yeah, thanks very much. And if I can take a couple of minutes here, I want to invite you to think about what is required by that health worker at the point of care. So we know that while quality care happens at that interaction between health workers and patients, families and communities, its success depends on a much more complex recipe. So what do you need? Something is in the competence of the health worker. There's something to do with the working environment. There's perhaps those essential structures, like do you have hand washing facilities available? And of course, it's not just a one-way relationship. There's the engagement and understanding of the patient as well. Unpacking any one of these demonstrates the need for that systems approach and the multi-level action that have been highlighted by all of the speakers today. If you take just the competence of health workers as one example, what does that take? There's training, supervision, support from leadership and colleagues within the working environment, regulatory systems, amongst many other actions. So I think the presentations today have made clear that the success of what happens at the facility level, the success of what happens in that interaction, including any discrete quality improvement initiatives, relies to some extent on that coherent approach to quality at multiple health systems levels. Supporting countries to plan and implement that multi-level action on quality is a priority for us at WHO, and we've been working alongside countries to try and understand how that can be achieved. I've put just in the discussion forum a link to the WHO Quality Planning Guide, which has been very recently released, that outlines some of the actions that can be taken at different health systems levels to create that fertile environment for quality of care efforts to succeed. And just noting here, of course, that this builds on a lot of work with countries, as well as the experiences that the QED network brings, as Dr. Maliki had described earlier. Within that planning guide, we outline 5 foundational requirements to support that delivery of quality care at the front line. One is the on-site support that's required to provide health workers with the necessary coaching, mentoring, and clinical skills support to improve quality. The second is measurement mechanisms, again, have been highlighted already, but to enable stakeholders to track the delivery of quality health services and promote accountability. A third one of those foundational requirements is sharing and learning to enable exchange of experiences in improving quality between and across different health systems levels. And emphasising stakeholder and community engagement to ensure regular, active and meaningful engagement in quality improvement efforts. And then finally, management to help ensure activities to improve quality of care are carried out within that functional support architecture. The planning guide then identifies some key actions at national level, district level and facility level to drive access on quality. I've not got time today to go through each action, but just to highlight a few actions here. On the national level, ensuring that national commitment, developing that national strategic direction, including a set of quality interventions, not just the frontline quality improvement methods, but also those broader interventions that can support quality care. Developing them that pragmatic quality measurement framework, and also thinking then into the operational and resourcing plans with key stakeholders. At the district level, there's a key role to play in facilitating that communication between national and facility level, responding to facility needs while also orienting health facilities to the district and national level quality goals and priorities, and maintaining engagement with both the national level and the facility and community levels. At the facility level, there's a real role in ensuring that those national level interventions are adapted at the facility level, but also that those cycles of quality improvement are being implemented, not just within specific projects, but also understanding the bigger picture at facility level, having a solid situational analysis that multiple stakeholders at facility level can buy into to understand that baseline assessment and identify gaps. Identifying then the range of QI activities that can support improvement and undertaking that continuous measurement of outcomes. I want to finish with just a deeper dive on one of the key recommendations that I highlighted there that's also outlined in the 2018 WHO, World Bank and OECD report on delivering quality health services, and also within the UN high-level meeting political declaration on UHC, which is to develop that national strategic direction on quality of care. The aim of developing that national strategic direction is fourfold, really. Firstly, creating that culture shift that's been talked about today to support providers to deliver, but also users to demand quality care. Bringing together multiple quality initiatives under a systematic and organised effort to improve quality of care, and securing that high-level commitment to quality through the stakeholder engagement and consensus building. And finally, to then clarify the structures for governance, accountability and monitoring of national quality standards. WHO has proposed a flexible approach to developing national strategic direction on quality, outlined in the handbook for NQPS. Again, I can't go into detail here. I'll post the link within the discussion forum, but just to mention the 8 elements of national quality policy and strategy that we would usually highlight. Firstly, they need to align with existing national health priorities and set some specific quality goals at a national level. Developing that shared local understanding of quality, that shared understanding of the challenges and a shared way of talking about quality. Engaging stakeholders across the system, including communities. Grounding the efforts in that national level situational analysis to understand the state of quality, as well as existing challenges and assets across the system. Understanding and optimizing governance and organizational structures, developing that multi-level set of quality interventions to shape the system environment, reduce harm, improve clinical care and engage patients, families and communities. Optimizing the health management information and data systems so that data on quality can be generated and fed into improvement processes. And then developing that core set of quality indicators, again, very linked to that previous element. Central to this approach is ensuring that throughout the development and implementation of any national strategic direction, the realities of implementation, such as we've heard from the 4 presentations today, those realities at the point of care can directly inform the national direction. It shouldn't just be this top-down approach, but rather this cyclical approach by which implementation is informing the strategy on a dynamic basis. We've still, of course, got much to learn, and we'll be working with countries to refine and improve these approaches as they're rolled out and to continue to try and generate learning on this subject. I want to just very quickly, briefly mention as well the recently released WHO technical package on quality in fragile, conflict-affected and vulnerable settings, which builds on these approaches in the most challenging settings, which of course account for a disproportionate burden from poor quality care, but require something of an adapted approach while the principles are the same. So again, I will post that in the discussion forum. Thanks very much, and back to you, Dr. Singh.
Thank you very much, Mike. Points well taken, and thank you for offering to share that strategy in the chat box. Also, we'll wait. I'm sure the audiences want to hear that. The point you raised was that it should be a force from the national quality policy and strategy, which gives a direction for the local administration and subnational authorities to work towards quality improvement, and then bringing out the coherence and learning from bottom as well, and feeding into the program policy management and administration. So now I would invite Catherine. Catherine has more experience of really working at a peripheral level in the facilities, and also have experienced the linkage with the governance at a subnational level. So Catherine, your view to the question. I hope you know the question, or would you want me to repeat the question for you?
No, I think I'm good, Semraw. Thanks so much. I think it builds off naturally off of Matthew's discussion. And I wanted to highlight that the policy document that Matthew shared, I think, is really helpful. And it also resonates very much with this idea of large social movements and change. There's a group called the Bridgespan Group that highlighted 5 key features of what's needed to create social change. If we think about quality of care and enhancing that as a social change and a social good, it certainly aligns with this idea of building a shared understanding, a set of winnable milestones, designing approaches that can work at massive scale, which I think we've heard about today about, what's that scalable unit and how do you increase change, that driving rather than assuming demand, and then finally embracing the course corrections. And when I think about these big, massive movements that we're trying to do and trying to create quality of care at all levels in health facilities worldwide, I think about how do you take all these kind of big goals and apply them at the front line of care. So a lot of the presentations that were shared earlier that were highlighting on this idea that a setting is ready or has the context to be able to take on a new intervention. I think we often get really stuck in this idea of readiness right now, that we measure very simple, measurable, easily quantifiable things. I call it the bean counting. It's like the number of beds, the number of deliveries, the number of hospitals that are in a health system. And what I think we have done is sometimes simplified out a lot of the nuance, which makes it more complex to do this work. And I think that's where the questions that Mike, you and Hema asked, they are complex questions. I think we need to embrace that complexity in some ways and start looking more at the nuance. So where that resonates for me and Semraw's point about connecting into the government in India, working in Uttar Pradesh, working with facility and district level leadership to try and identify what worked well in the Better Birth trial, where we implemented the WHO Safe Childbirth Checklist and created change in behavior, but didn't have impact on mortality. We took some time to unpack the why. And some of the core questions and core answers that came in unpacking the results from the Better Birth trial really came down to this idea of, is a place in a setting have the context to be able to take on quality improvement, or is it just adding more to the mix of what people need to do on their everyday basis? And so we've been trying to think a lot about, what does it mean to measure context? What does it mean to measure readiness? There has been the conversation even here today, I hear us talking about it more broadly, that it's not just, again, about the number of beds, the number of staff, the number of deliveries that are happening at a facility, but it's a more in-depth, nuanced look at what does it mean for a facility to take on a new quality improvement or a district or subnational or national level improvement. So some of the other areas that we think are ripe for innovation are really around measurement of some of those more nuanced characteristics that we think set sites up, set locations up for success and quality improvement, and meeting those large, lofty goals and the winnable milestones, and kind of the definition of success that Matthew mentioned and is included in that idea of creating massive change. So some of those areas that I've been thinking quite a bit around, how do we measure leadership? What does it mean to measure leadership at a facility level, at a district level, at a national level? And it's not just about words and engagement, but it's really about the actions that leaders take in engaging with frontline healthcare workers at in the facility level is what we saw particularly being important, but also the communication patterns. And measuring communication is not necessarily an easy thing to do, but how do we think about communication as a part of readiness or a part of the context assessment? Thinking about the workflows that need to happen in order to integrate new interventions and new implementation strategies. Again, how adaptable are workflows? How set up for success are these new interventions that are being layered on and into frontline facilities or district or national level? And then a third area is around this idea of motivation, and not just for individual staff. I think we've seen a lot of discussion right now in the era of COVID around provider burnout, but understanding about motivation for providers, managers, understanding motivations of government is really an important piece of understanding that context and areas for improvement and quality improvement and being able to make change. So I just wanted to give 3 examples from the trial where these are things that we did not measure and wish we had understood more about, but that idea of communication. So when we looked at high mortality facilities in the Better Birth trial, we did some qualitative work afterwards to try and understand what were some of the key opportunities and challenges at that facility and where were things working well, even though it was a high mortality facility. And what we saw is that in the high mortality facilities, the frontline staff, the nurses and nurse midwives noted that they didn't have the ability to make decisions without approval from a lady medical officer or their direct supervisor or a senior person. And in the low mortality facilities, those frontline decisions were enabled and empowered at the front line. So right now in context assessment and readiness, we don't measure empowerment of frontline staff. So when we're thinking about quality improvement and quality of care, that's an area of, that we need to be measuring better. The second is around that idea of motivation. Again, how do we measure that motivation? We don't have, or I am not aware of clear methods on how to do that. I would totally appreciate it if any of the attendees have information on that. We'd be happy to think about how do we incorporate that into context assessment and readiness. And then the third, I think, is some of a really simple thing that I wish we had measured, which had to do with security at the facility, how safe the staff feel, how safe the families feel that were attending care. So all of those pieces of readiness or context assessment that we're sometimes not measuring right now, I think make a huge difference on the ability of one individual facility or a whole health system to take on quality improvement and quality of care goals as a strategy. And so I encourage all of us to think more broadly about what we're defining in terms of readiness and context, and how we think about, engaging in that more deeply and in a more nuanced way to be able to actually create these large scale, massive changes that we want to see. Thanks.
Thank you, Catherine. And those points were very well stated, linking what Mike said earlier about the software, focusing on the software, who are the ones where the behavior change and the practices have to change, and looking into the systems. Yes, our systems, especially coming from India, do not invest too much on-job learning. We will see that largely missing. And then the motivation of the staff, there's work satisfaction, and then linking them and making them do things for better quality is also requires respecting them space and their work. That point we tend to miss a lot in the context. Thank you for making that point. Before we move on to the next question, Karen, would you like to come in, say a few things, or just take up the session from here now? Karen?
Hi, Samiksha. Yes, just wanted to flag again, if for the participants that are still with us, to post your questions in the live Q&A. There was a question for Claudia, which I think has been answered. And the next part of the session, I will invite Hema and Mike to talk about their reflections on where do we go from here. How can we support a culture for quality improvement, and what role we've heard about in all the presentations about the importance of data. So what role for strengthening capacity for the use of data in decision making? So over to you, Hema, and then Mike. Thanks.
Sure, thank you, Karen. And, you know, I think it's hard to disentangle when thinking about future directions and how to really make the change that we want to see. It's hard to disentangle some of the responses from the first question to this question as well around culture and data. So forgive me if I repeat a bit of the concepts that have been touched on by others, but they frame kind of the perspective that I have. So I think that overall, just kind of the way that I have been thinking about, both through the experience I've had in implementation and research, as well as the global literature and kind of connecting these dots, has been that, you know, we as a global community is really starting to understand more clearly that while standard QI as a methodology used by facility teams can be effective in bringing about change, there really isn't a lot of evidence of sustainable or large-scale impact of that micro-level QI alone. And I think that's pretty clear, you know, and I think that we get that, we see that, and that hopefully is, you know, not too much of a debate. But then it's sort of but then what else? What else do we do? How do we do this better? Do we abandon it completely and say, this doesn't work, we just got to try other stuff completely? Or do we adjust, adapt, think about it in broader or different ways? And I think the perspective I bring is that if quality improvement is part of broader quality management systems, there is a much stronger ability to move beyond this micro level change. And we are seeing evidence of that. And I think that having stronger, both rigorous implementation that enables the evidence generation that's required to actually show this in evaluations rigorously is critical. Because otherwise we're just going to lose a lot of important learning in and not actually inform these big questions that need to be answered in the world. And I'm heartened that, you know, some of the experiences highlighted here and the work coming out of the QED network and Ethiopia and in India are really trying to get much deeper into these questions of the sustainable change, not just demonstrate that it can happen. And get into that deeper nitty-gritty of, you know, not only does this work in a small scale, but does it work at a bigger scale? What are those steps to scale? Does it work when those same activities and core intervention components are implemented by government actors, not partner actors? All of that is kind of where the rubber meets the road when we're thinking about large-scale institutionalized change. So I think that this comprehensive system approach is really based on kind of 3 core concepts illustrated in some way, shape, or form, you know, even if not using the specific language by many of the examples today. One would be strong quality planning and governance. So really trying to support leaders and leaders at that both macro level, which is, you know, has certain needs, as well at the national or federal level, as well as then at more meso levels, kind of the regional or the district, whatever, they all have kind of slightly different planning responsibilities and governance responsibilities, but really enabling them to have the skills that are needed to design the system within that administrative unit, to have the resources needed, like the budget, the HR, the equipment, the infrastructure, the data systems, and establishing then a culture of data use for effective leadership. And that has to happen by example. You have to do that. You have to believe in that. It's not just words. We've all been in meetings where, you know, people will say, please use data for, you know, we're just improving. But as soon as you walk out in the tea break, it's, but make the neonatal mortality look better. You know, this is just the world in which we live. And so how do you get beyond that is through this kind of hard work that takes time. And 2, so another concept would be this concept of quality control. And that's really about the act of routinely monitoring the performance of your system. So whether it be a DHIS system or a data system or other, to minimize that variation and identify when there are major changes, like never events, maternal deaths, others. So this is kind of where your data, your audits come in. And then finally, the quality improvement. And thinking of this as really intentional planned introduction of system changes that are designed to address kind of problem analysis, root causes of the problem you're trying to change. And that, you know, if done well, can really help bring the system performance to a new level. And so those are kind of three core concepts, but those three components really require a delicate balance to move from a system where you've got competing and fragmented micro efforts into a supported and integrated system where you have quality planning that is guided by frontline learning and improvement, and the integration of those improvement efforts into a routinely monitored and controlled system. This kind of may sound like a lot of talk and jargon, but you know, I think what it looks like otherwise is that you've got some facilities where you're doing a lot of MPDSR and some facility audits. You've got other facilities where they're just really excited to share their PDSA. And then you've got somewhere else where you're really focusing on telling people what to do and what they're doing wrong, and that kind of command and control. So I think that's where how to change that into this much more connected system that is aimed, has the clear North Star unified as the goal and vision is really what's necessary. And a backbone of this strong quality management system requires data. And that data has to flow across the system continuously. That data has to be trusted and reliable, and people have to use it in meaningful ways. So efforts to create and strengthen that data have to be tailored to addressing the specific gaps in a country. And, you know, I think very often we kind of discuss data as around, oh, it's poor data quality. But what does that really mean? And that's where you got to get under the hood is, you know, is this data quality and kind of a typical use of that word of being kind of discrepancies, paper and electronic, and data entry issues, or, you know, we have many domains of this, of what are data quality. But then there's often other types of data quality, more in the realm of kind of falsification or distorted incentives that kind of really kind of compel actors to change their data. And really thinking that has a different root cause. That's not like no training, you know, little trainings aren't going to fix that cause. That is much more around the culture of data being used for punishment and a lack of experience of data being used for something more positive. And so to change those mental models requires user capability building at not just the frontline level, but also at the manager level. Managers and leaders need to see data as a tool, not a threat. And that is what's necessary before you can start building trust and start seeing this culture change. And so that kind of true change in data use requires the change in those data use principles that starts at the leadership level, but then also practical experience where data is used and leads to being able to someone doing their job better. So I think that's where I'll end my reflections and hand off the mic to Mike to share his thoughts.
Great, let me just dive straight in then rather than take more time. So I hope people are still out there and still listening. I really enjoyed listening to my colleagues. I'd like to start off with some anecdotes, because I think they can be pretty interesting and illustrative of the challenges. So I think it was Catherine earlier talked about what matters to the community and empowering communities, and you know, getting change to happen will involve everybody everywhere. So the anecdote comes from a country I know very well, it won't take too much to guess, where during an election year, the entire public health system was closed for 7 months because of strikes. Yet the incumbent government was re-elected. So I think that probably tells you that people's health care, or the healthcare services that were being provided by the government, were actually not uppermost on people's minds, or they didn't feel that their vote counted. So accountability had failed. Sadly, I'm not the person to solve that problem, but I think it just reminds us of what has been said earlier, that a lot of what we do is dependent on working across so many sectors, and if quality doesn't matter to the people that the services are intended for, then we aren't going to get very far, because ultimately politicians get elected, hopefully, or if they don't, we're in trouble anyway. So that's just one anecdote. The second anecdote is really about it's not an uncommon thing for when I have visited facilities, and is to take somebody, let's say, working in a part of a hospital, and say, well, why don't we just walk down to the outpatient department or something? And they will literally tell me, you know, I've never met these people. And you think, well, where do your patients come from? You know, how come you've never met the people who are sending me patients every day? But that isn't uncommon. And I think for those of you who are in healthcare, you may recognize that. And the same, I've very often talked to people who say, oh yeah, I've seen that, that's terrible, that's awful, it should never happen. And you say, well, why does it happen? So, oh, well, I couldn't possibly mention it. I couldn't raise that as an issue. You know, it's much too sensitive for me to talk about. And I think what I'm getting at with these anecdotes, with the second two at least, is that it does come down to the way people feel about their work. And I think this has been mentioned repeatedly. And there is a power in data, and it's necessary. But if it stops at data collection, and it is something that people feel that is only being used to monitor them, it doesn't work very well, because they're not engaged in the process. And I think Hamer is making the same point, but it's just to elaborate on that. So there's a terrible tendency for the top to think of data as serving the policymaker, serving the major regional manager, so that they can then do something. And many systems start with that premise. And actually, very few people ask and I think this is one of the big advantages of the real QI, if I can call it that, is that they ask, you know, what some of the issues are. Well, what data matters to you? What's important to you? And let's try and measure it. So I think we need to be clever with data as well, and what we do with it. And I definitely, so there's this, everybody I'm sure has heard this adage that if it's not measured, it's not managed, or if you can't measure it, you can't manage it. And that's just clearly nonsense. No manager in their right mind would be trying to measure everything that they have to do every day. So we need to move away from that and realize that most of us are in one sense or another a manager. And we are mostly having to manage things that we have no intention of measuring, and it would be impossible to measure anyway. That doesn't mean to say we shouldn't have important data, but it is one part of things. And I think the other thing for anybody and I would encourage people to read a bit of Mintzberg, is healthcare is not a factory. You can use important insights drawn from production methods, but healthcare is not a factory. Healthcare is a professional bureaucracy. And that means that professions and professionals are actually what makes things happen. And we've often I would say, completely neglected a very important part of the health sector, who actually create what is normal for the way people work. So if you are trained in a setting where the senior is very rude to people and pays no attention to their needs and pays no attention to their team's needs, then that is the norm that you see, and that's the norm that you'll practice. Changing somebody who has learned in that way is very difficult. So my opinion is that we need to think very carefully about how we engage the broad sectors that we've all been talking about much more actively. It should be a profession, I'm running out of time, I can see. A part of our identity as professionals should be to produce quality work. And that is the aim, and that will contribute, I think, to this broader picture, but I should shut up because we're just about out.
Thank you, Mike. That was very thought-provoking, because in professionalism, we have to also look at doing the work with quality, which is missing. We are close to the end of the session, and I see a question, and it is open for the panelists. Anybody can take this question, which is interesting. The question says that in all the topics they heard, the approaches were more emphasized on a specific health topic or a department. However, QI should be a system-wide approach. So the question is, what are the panelists' thoughts on tackling a facility-wide QI rather than a department-specific QI intervention in any facility? Anybody volunteering? Yes, Hema.
Sure, I can try to give this a shot as well. I think that's a really good point. You know, I'll say that from my experience in Ethiopia, this was brought up very often, and the way that we thought about it was really trying to target efforts at different outcomes. So the entire kind of strategy and capability building work was aimed at the outcomes that the government had laid out of building quality governance structures across all facilities. So your internal medicine had QI teams, and your surgery ward had QI teams, etc. And so there are efforts happening to support this kind of broader culture that across the facility. At the same time, we also saw and were asked to help drive improvement in kind of a priority area as a place to start, help show the rigor. And that's also a way of interconnecting with that culture that's developing across a facility, a district, a zone, whatever that might be. And so that's where there was a duality of both a kind of results-driven, kind of rigorously implemented, monitored, evaluated component in maternal and newborn health as an identified government priority that complemented this kind of more broader facility-wide approach. And then now in that second phase that Abiyu spoke to, the focus is actually no longer on MNH. Those kind of primed systems have decided to make their own decisions as whether they are achieving the results they wanted in that kind of earlier space where they are, and now focus efforts on new priorities. So it's really kind of building in this approach to thinking and problem solving and problem identification and problem solving to address population health needs.
Right. Thanks, Hema. Because you mentioned Abiyu, I would like Abiyu to also answer this. How did you link the QI with the QA and bring the QI culture across the departments, if you were able to see that?
Thank you. I think it will involve multi-level intervention, including structural arrangements and trying to demonstrate how it could be applied across the system. And in practical sense, we tried to utilize, for example, an MNH project. And when we design that MNH project, our intention is not only to stop with MNH, but also expand into others. So during capability building activities, we try to build the capacity of a QI unit instead of just only focusing on MNH unit QI lead or QI focal person. So that the responsibility of that QI unit lead would be to initiate projects across different departments. And I would recommend for facilities to have similar type of structures where someone would become a responsible body to initiate and to become a body to build capacity across the facility so that each facility could run quality improvement initiatives within their scope, plus the leadership of the facility would take also high-level QI projects where a priority set by the leadership could also be executed in a form of quality improvement, and that way QI could be done at the top and at the bottom levels of the facility structure. And I believe that the principle can be applied across every department once a demonstration project gets implemented in one specific unit as a lesson.
Okay. Thank you, Abiyu. And we are 4 minutes post time, and so I guess it's time to close. So I would like to thank all the presenters and the panelists for their insights into the very complex topic, and we are all still figuring out what works where and what the contexts are. So it was a very thought-provoking, and the take-home messages first try and understand what the context is and how you bring in the quality improvement and assurance components together and in different aspects of health system, not just looking at the evidence-based practices, but at layers of health systems and aspects of health systems, from resources to human resource to practices to the culture and administration also. So that would be the takeaway from our session today, and thank you all, and special thanks to the participants who attended this session. If you may have any questions, and if you have posed any questions to us in the chat, we'll try and write to you through email, and you can find all the presenters and panelists also and write to them on their emails if you have any questions to follow up. Thank you, everyone, and have a nice day or a good evening wherever you are. Thank you all.
Thank you.